Good evening to you all. I'm Dr. Rohit Pai. Thank you, Dr. Sudhir Gupta sir and Dr. Shona madam, to give me this opportunity presenting seventh year in breast cancer. I'll be talking about some abstract, some studies in translation science in breast cancer. To start with, pembrolizumab in patients with metastatic breast cancer with high tumor mutational burden results from the TAPUR study. So this study was conducted in breast cancer patients, 28 patients from 2016 to 2018. They had high mutation burden ranging from 9 to 37 mutations per megabase pair. Most had undergone foundation 1 testing. If you see on the right side, if you look at the prior treatments, they were heavily retreated. So 3 or more than 3 treatments, almost 93% of patients, they had received pembrolizumab in standard dose. Simon's two-stage design was used as a primary endpoint of study and was a disease control defined as objective response or stable disease of at least 16 weeks duration. One of these 28 patients was MSI high, and both triple negative breast cancer patients and hormone receptor positive patients, as well as a few HER2 positive patients, were included. Triple negative breast cancer patients were 13 out of 28, which constituted 46% of patients. So if you look at the response rates, you are seeing that there was a significant response across tumor types. If you look at the waterfall plot also, so both triple negative breast cancer patients as well as the non-triple negative breast cancer patient responded. If you are seeing the total duration of response or the time on treatment, the highest response is for hormone receptor positive, HER2 positive disease patients, followed by triple negative, and even one triple positive patient has a remarkable time on treatment more than 1 year. So across the board, if the tumor mutation was high, the patient did respond. Essentially, you have a approval for pembrolizumab for site agnostic approval for high TMB patients, more than 10 mutations per megabase pair, 10 or more than 10. The data which was available when this study was started, number one. Number two, in the pembrolizumab approval study, no patients of breast cancer were there. So this is a breast cancer specific cohort. Number three, in patients who have exhausted all their treatments, should we offer comprehensive genomic profiling? This TAPUR study had shown a median progression-free survival of 10.6 weeks, median OS of around 30 weeks, but a very significant time on treatment for certain breast cancer patients, both in triple negative as well as the non-triple negative subgroup. Next abstract would be genomic and transcriptomic correlates of immunotherapy response in patients with leptomeningeal metastasis. Here, what you are having is 19 patients. 2 studies with studying either pembrolizumab or nivolumab ipilimumab, 10 of the with pembrolizumab and 9 with nivolumab ipilimumab. 2 different studies. They were basically given immunotherapy and they had leptomeningeal metastasis, and it was not only breast cancers, there were a few patients of other cancers also. CSF analysis was done prior to giving immunotherapy and post administration of immunotherapy, and in 9 of these 19 patients at multiple time points. Single cell RNA sequencing was performed, approximation projection was done. According to the transcriptomic signature, the cells were classified into 2 cell clusters, either immune cell clusters or non-immune cell clusters. The non-immune cell clusters, their copy number variation analysis showed similarity to the primary tumor. Obviously, you have the cancer cells in the CSF, that is where the patients are having leptomeningeal metastasis. And there are other immune cell clusters also. Now we come to what was the results after giving immunotherapy. I would like you to just focus on the right-hand top 2 graphs. In them, in patients treated with nivolumab, ipilimumab, what you are seeing in the third graph, the third box plot, the number of CD8 positive cells in the CSF increased. That was not the case with pembrolizumab. On the right side, what you are seeing here is the actively cycling CD8 cytotoxic nivolumab and pembrolizumab. So in nivolumab, the number and activity increased, nivo-IP. In pembrolizumab, the activity only increased. But definitely there was an interferon gamma signature towards the right, towards the bottom of the graph, which correlated with the increased immune response after giving immunotherapy. And you are seeing an early as well as a late response in certain patients. So early is less than 30 days after administering the immunotherapy. more than 30 days, also some amount of immune efficacy was present. The interferon gamma signature was divided into those in the immune cells and the non-immune cells. Remember, there were two different clusters, and the interferon gamma response in the non-immune cells also correlated with the total duration of treatment or total response rates. Also, a less immunogenic subclone of the disease which might increase and cause a progressive disease. So this was an interesting patient, 43, number 43 patient. It was patient, so it was proportion of cells by time point. And here what you are seeing is, in the first graph, what you are seeing is CSF cytology, sequel and cell-free DNA. They are all going down after immunotherapy and then increasing. And why is it so? So you are having these two clones towards the right hand top corner. You are having these two clones. Look at the bottom. In dark purple, the clone is immunogenic, that is reducing. The less immunogenic subclone is increasing. And that is why you are having in the center a radiological progression. So less immunogenic subclone might appear when the patient is having treatment for leptomeningeal metastasis on immunotherapy, with immunotherapy. So this is a clinical data. So this was a sort of a clinical data to phase 2 study of nivo-EP in leptomeningeal carcinomatosis, 18 patients, any histology leptomeningeal mets, no intra-CSF treatment during the study, so no IT, MTX, etc. Overall survival at 3 months was the primary endpoint. 6 out of 18 patients should be alive at 3 months. So for the study to meet its primary endpoint, all histologies were included. 8 patients out of these 18 were breast cancer patients. What you are seeing here at the bottom, a significant number of patients were receiving corticosteroids. Around 77.8% patients were receiving corticosteroids. One patient had complete response, 7 patients had stable disease. 8 patients out of 18 were alive at 3 months, median overall survival 2.9 months. 1/3 had grade 3 or higher adverse effects, with 2 discontinued due to immune-related adverse effects. So nivolumab, ipilimumab is a relevant combination in this early stage, early phase trial to treat patients with leptomeningeal metastasis, number 1. Number 2 is that there is data which suggests that nivo-EP has CNS effects. Not just nivolumab does not, but nivo-EP does have some CNS effects. So maybe in patients with leptomeningeal metastasis, this is one option in patients who are affording and have exhausted everything. This is another interesting study, single cell spatial analysis by the imaging mass cytometry and immunotherapy response correlation in triple negative breast cancer patients. So this was the NEO-TRIP trial. And what was the trial? There was randomization of NACT, carbonate with atezolizumab or without atezolizumab. And the event-free survival was the primary endpoint, which has not been as of now analyzed. But you are seeing that the pathological complete response rates are numerically higher with atezolizumab as compared to only chemotherapy, that is only paclitaxel carbo, 4.64% difference, but it is not statistically significant. In these patients, the tissue was subjected to mass cytometry, and mass cytometry is basically fluorescence attached to heavy metals rather than other molecules. So mass cytometry, and you can have multiple studies on a particular cells in mass cytometry. That is the advantage rather than the fluorescence being confused. So these 43 proteins were studied in the tissue, and they underwent imaging mass cytometry. And so as I mentioned, pure rare earth method reported antibody conjugated were taken and profiled at 1 micron resolution. So here you are having DNA, pan-keratin, and marker. DNA is in blue, pan-keratin is in green, and markers. What the markers are studied? The markers are studied. They are red. So you are having all these markers like IDO, PD1, OX40, etc. And on each 1 micron tissue sample, it is being studied. For H&E specimens, they were divided into 3, which encompassed all the tumor. So basically the tumor as well as the tumor stroma interface was encompassed in the H&E samples. So basically 2 slides, 1 mass cytometry, 1 H&E, encompassing all the tumor microenvironment and tumor stroma. So single cell segmentation was done. So cells were divided into tumor microenvironment types or epithelial types. So which of the cells, so whether they are epithelial or they are outside the main tumor in the tumor microenvironment. So there is an association between cell phenotype diversity and pathological CR. For example, benefit of immune therapy was seen in CD56 positive neuroendocrine cells in the epithelial component and PDL1 cells expressing the IDO, so indolamine 2,3 dioxygenase antigen presenting cells in the tumor microenvironment. If they were present, they correlated with response to immunotherapy. There were associations also. So according to whether it is in epithelial or tumor microenvironment, the pathological CR was also correlated. So if it is in the epithelial, you are saying that HLA-DR expression and Ki67 expression predicts for immunotherapy benefit. But if it is in the microenvironment, Ki67 still predicts benefit with immunotherapy, but HLA-DR does not. So rather than having an IHC on a simple tumor, where exactly are those proteins expressed, whether epithelial or microenvironment, also may have an impact on benefit with immunotherapy. What about the spatial connectivity? So this was extremely important and interesting. So if the tumor, if the epithelial and the microenvironment cell is very close, if there is a low degree of interaction in certain, so it's not very close, there's a medium degree if it is intermediate, and if it is very close, it is a high degree of interaction. And this was also significantly correlated. So if there is basically a tumor, if there is an immune cell, you are seeing all these immune cells at the bottom with a significant p-value, PDL1 IDO positive cells, CD79 positive plasma cells, CD20 cells, CD8 cells. If they are close to the epithelial cell, if they are close to the tumor also, there is a benefit with immunotherapy. So where exactly are these immune cells actually reaching, whether they are reaching the tumor or no, spatially speaking, is also important. And maybe this is a potential biomarker of the future. As of now, this is a very complicated technique, but yes, something to think about. Was the next abstract. So analysis of mutation status and homologous recombination deficiency in tumors with germline BRCA1 or BRCA2 mutation and metastatic breast cancer. So this was a subgroup of patients in the Olympiad study. Olympiad trial studied compared olaparib to physician's choice chemo 2:1 randomization in HER2 negative advanced breast cancer. So it included hormone positive as well as TNBCs with germline BRCA mutation. So patients needed to have a germline BRCA mutation. Olaparib demonstrated PFS benefit 7 months versus approximately 7 months versus 4 months. In this study, tissue samples were analyzed with the Myriad My Choice companion diagnostic test. HRD score of 42 or more was said to confer HRD. HRD is the unweighted sum of loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. Loss of heterozygosity basically means you are having an inherited mutation, that is a germline mutation, and the somatic cell is also, so the other normal allele is also going in. So because of the inherited mutation, you have heterozygosity, one normal, one abnormal. When there is a somatic mutation in the normal one, there is a homozygous abnormal. So basically, you have a loss of heterozygosity, which is leading to homologous recombination deficiency, and which is leading to genomic instability causing cancer. So this is the pathogenesis. So this HRD is a weighting of all these three parameters, and 42 is the scoring. So this study basically looked at whether there is a concordance between tissue and germline, whether there is any added benefit of testing the tissue also, if you are planning to start the patient on olaparib. What about the concordance between germline BRCA mutation and tissue BRCA mutation? It was seen in 99%. So 142 out of 143 showed a tissue BRCA mutation, right? And as per the Myriad test, if you have a tissue BRCA mutation, irrespective of your HRD score, you are reported as having homologous recombination deficiency. Absence of gene-specific loss of heterozygosity. So basically, the normal one still remaining there. It's not abnormal, so it's not mutated. You're not having that extra mutation. Was seen in 7 patients out of 125. Response rates and survival were similar, irrespective of HRD positivity. With less than 42 score was also seen in 16%, but the responses were similar. So I would just like to see these 7 patients. They did not have loss of gene-specific heterozygosity. 2 of these patients had additional mutations. If you just look towards the right side at the top box plots, so you are having BRCA1, the HRD score is significantly higher than that of BRCA2. You are having ER positive and progesterone receptor positive tumors, which have a HRD score slightly less as compared to those of triple negative breast cancer patients. But if you are looking at these responses, you are having across subgroups hormone receptor positive with low HRD, as well as triple negative with low HRD across subgroups, you are having a significant benefit with olaparib. So technically speaking, your HRD score is not predicting for benefit with olaparib, and there is no role of doing it additionally in the tissue if you are planning treatment with PARP inhibitor. That is the message which is to be given. Inflammatory cytokines and distant recurrence in HER2 negative early breast cancer. Again, in this, adjuvant treatment was given with paclitaxel, with or without bevacizumab, plus hormone receptor with endocrine therapy. So basically, there were 250 pairs, case-controlled pairs, with or without distant recurrence were taken. And what was studied was the baseline cytokine level, which was analyzed with this human cytokine 36-plex kit. These 4 cytokines were interesting. So interleukin 6 had a hazard ratio of 1.37 for distance recurrence. There were other 3 cytokines, interleukin 7A, macrophage-derived chemokine VEGF-A, which also showed higher recurrence rate. The p-value was numeric, was less than 0.05. But if you took for multiple testing, the actual p-value less than 0.014, which was the significance level, was only seen in interleukin 6. Again, a higher body mass index was correlated with higher interleukin 6 levels. If you divide the level of interleukin 6 in 1/3, so tertiles, you are seeing on the left side the cutoff of 1.37. So above that, there was a significantly inferior survival with high interleukin 6 levels. Higher levels of pro-inflammatory cytokine interleukin 6 associated with higher risk of recurrence. Hazard ratio is 1.37. The cutoff is also 1.3 picogram per ml. Association of interleukin 6 and obesity. There are other 3 cytokines which are also associated with the inferior outcome, but they have not reached the significance level which was seen in the study. 1B evidence supporting IL-6 as a prognostic biomarker. Additional validation, or maybe you can have a targeted agent for the IL-6-STAT pathway in the future. Gut microbiome on response to NACT in early stage TNBC. This was again longitudinal fecal samples were collected in 85 patients of early TNBC in a trial which studied 4 cycles of neoadjuvant doxorubicin cyclophosphamide. In the trial methodology is after those 4 cycles, you study the tumor. If there is a less than 70% reduction in the tumor, you add something more to improve the response. In this baseline fecal sample, post-neoadjuvant therapy cycle, pre-surgery, post-surgery fecal samples were collected and the microbiome was studied. And in this particular report of this study, the microbiome at baseline only has been reported in patients with pathological CR versus patients with residual disease. There is a significant difference in patients achieving pathological CR versus those with residual disease. So patients with residual disease have more of bifidobacterium longum, lacnospiraceae, and bacteroids theta iota micron. So basically, microbiome might predict benefit. The baseline microbiome, the pre-treatment microbiome also might predict response to neoadjuvant therapy. This is the last abstract, my pathway HER2 basket study, pertuzumab, trastuzumab, tissue agnostic cohort of patients, HER2 positive advanced solid cancers, no satisfactory treatment. So pre-treated patients, colorectal, biliary, NSCLC, urothelial, salivary, many patients, pancreas, so many patients were included, treated with pertuzumab, trastuzumab, standard dose. And the data cutoff is till March 2021. HER2 testing was done with either HER2, the FISH test, or the next gen sequencing based on copy number gain, or IHC 3+. HER2 mutation patients were not studied. So this report is only having HER2 amplification and mutation or overexpression. So what were the overall response rates? Objective response rates in 60%, disease control rates 44.6%, duration of response 7.8 months, and overall survival, median overall survival 10.9 months. If you look at the patients with KRAS mutation, so there were a very poor objective response rate of 3.8%, disease control rate also 3.8%. So HER2 positivity might predict benefit with HER2 directed therapy. KRAS mutation might predict lack of benefit, something like cetuximab and panitumumab, lack of benefit with HER2 directed therapy. Look at the overall survival also. The PFS is more or less similar to the right, but you are having a significant better overall survival in KRAS wild type patients, 12.6 months versus 5.7 months. And essentially, As far as the responses goes, very high responses seen in colorectal as well as salivary, more than 60% in salivary. Reasonable responses seen in lung and biliary cancers. And KRAS mutation, again, might predict lack of benefit with HER2 directed therapy. I have come to the end. Thank you.